participate even without an abstract, because it is an opportunity for all of them to listen to their friends, as well as there is a case presentation and a OSCE session also. So all the teachers kindly ask their students to attend. I offer all the best to
Riya's IMA program, actually we have taken that. അങ്ങനെയാണ് രേഷ്മയെ വിളിച്ചത്.
Okay. Thank you, madam. Thank you.
So good evening all. I'm very happy to have two young ladies presently here. Dr. Rekha, our Vice President, and she's the Associate Professor of Pediatrics in Gokulam Medical College. And we'll hear from Dr. Rekha on complementary feeding. The complementary feeding day is on August 6th, and IAP Kerala is also organizing very many programs on complementary feeding. And I think we have actually started the complementary feeding week program. So over to Dr. Rekha Isnair. Dr. Rekha, can you share the screen?
Yes.
June 6th. June 6th. June 6th. പറഞ്ഞത് തെറ്റിയതായിരിക്കും. അല്ല പറഞ്ഞതാണ് തെറ്റിപ്പോയതാ.
June 5th Environmental Day ആണ്. June 5th.
June 6th എന്ന് വെച്ചാൽ 6th month 6th day അല്ല, ലൈക്ക് ദാറ്റ് അല്ലേ? 6.
പക്ഷെ അതിനു മുമ്പേ June 5th Environmental Day ആണ്.
അത് 5th. 5th. So that also actually there are many programs on the anvil. Dr. Bennett, you want to tell anything? Bennett has recently retired, and our national president actually went to his house, and nobody can expect such a thing, isn't it?
Thank you, madam. No, actually, because of the Yuva conference, they all came to my house. Anyway, this topic is very, very important, especially for we have to think about the hidden hunger, which is there with the children, especially after 6 months of age. Our main problem nowadays is the adolescent with anemia, because anemia Mukt Bharat, that is the aim of our national level, both the Prime Minister and our IAP. So the thing should start from beginning itself, because most of the children are facing the problem of micronutrient deficiency, especially iron deficiency. So complementary feeding is very much important. And anyway, thank you very much for this topic, and thank you very much for giving this opportunity. Bye. Okay.
Over to Rekha.
Thank you, madam. Are the slides visible, ma'am?
No.
Just a second.
You can share it again. Yes. Now it is visible.
Okay. Thank you, madam. At the onset, thank you. I'd like to congratulate IAP for this wonderful tutor series, which is very informative for all of us. And I'd like to thank Dr. Srijit and Kalpana madam for giving me this wonderful opportunity. And I'd also like to use this opportunity to thank all my teachers in pediatrics who made me eligible and for such a talk in such an elite group. Actually, when madam told me the topic complementary feeding, I was a little confused, because what am I going to say extra about it? Because this is like almost like attending a viva. It is like talking to a whole panel of experienced people, where everyone present here is an expert on the topic. So for me, this is just a discussion. So I thought I'll just go through the topic, but then I understood that this is very much a needed topic, because this is something which is very important to us on a day-to-day basis in our day-to-day practice. At least 10% of our OP constitute of parents who come to us with for dietary advice. And having a discussion will definitely help us to discuss better and to counsel them better. So going on to the topic, the right to adequate nutrition is a fundamental right for every child. So children, and it's quite clear to us that children who are fed enough of the right foods in the right way at the right time are more likely to survive, grow, develop, and live to their full potential. So that takes me to my topic today. So of course, the right feed starts with exclusive breastfeeding, which we don't have, which we have almost with all the interests that IAP and all are taking now. Exclusive breastfeeding has almost become the dictum. But now what we are facing is the children are having a good weight gain till 6 months. And after that, they start faltering in the weight. So at 1 year, when you see a child, the weight is very much on the lower side. But if you go back and look at the weight, the birth weight was good. The initial vaccination time, the weights which they have seen are all good. So that takes us to the point that where did we falter? It's actually we faltered. The breastfeeding did not falter. At 6 months, they had adequate weight. And after that, the baby starts losing weight. So that here comes the importance of complementary feeding, because that is where the parents need to be taught, actually taught what to do, because many of them don't know what exactly to do. And complementary feeding is defined by definition. It is the process of providing suitable foods in addition to breast milk when breast milk or milk formula alone is no longer adequate to meet the nutritional requirements. And generally, this starts at age of 6 months and continues till 2 months. We allow breastfeeding at least till 2 months is good enough. This is as per the WHO guidelines, and WHO has revised the guidelines, and it considers now the needs of both breastfed and non-breastfed children. The UNICEF guidelines are also very much similar. Now, it is the process. Complementary feeding is a process by which the infant actually becomes accustomed to a adult diet. The complementary feeding period is also a critical opportunity to prevent all forms of what we say later, the childhood malnutrition, as Vanessa was saying, even that including the stunting, wasting, the macro and the micronutrient deficiency. And not just the deficiency, the overweight, the obesity, and what we see most today, the diet-related non-communicable diseases. Especially that has become a very important topic when it comes to the adolescents. In addition, this is something which we often overlook. Lifelong food preferences, the taste and the habits are often established in childhood. We now blame the adolescents or the adults as that for the junk food they eat. But why do they develop this taste towards junk food? That is probably because of our wrong, it's mostly because of our wrong complementary feeding. Because their taste developed at a very early stage, and at that stage we fall. Unfortunately, the complementary feed, courtesy Elizabeth Madam, this is also the weakest link in nutrition, where many of the children directly fall into the pit of malnutrition. So this is where we falter most when it comes to in the path of nutrition. And as the infant grows and as the intake of the breast milk decreases, there is a food gap, and the amount of the food which is required to cover that gap increases. Hence, here the quality, the quantity, and the timing of the complementary feeding must be adequate to meet the nutritional requirements the baby has. So very rightly, June 6th is being celebrated as a complementary feeding day. And the purpose of celebrating a day is more like a reminder to the importance of the topic. And the theme for this year is timely, adequate, safe, and active feeding for all children. The slogan being for an optimal growth and a healthier tomorrow. Now, the main question, when to start complementary feeding? We all know that a few years back, even WHO used to promote a 4-month complementary feeding, and which was later changed in 2014 to 6 months. So why this 6 months? The introduction of complementary feeding around 6 months, because 6 months is the ideal time or the most sensitive period for starting complementary feeding. We'll come to the details. If the introduction of complementary feeding is delayed beyond 6 months, the child may get into or enter into the critical period, after which the infant will remain a poor chewer and remain poor in eating solids. And later on, this is what leads on to the malnutrition. The effects may be seen much later. Now, complementary, and why not before 4 months? So at this age, the infant is not developmentally ready to eat any food other than milk. Here, where we have to take into consideration the formula as well. This is because the saliva production, developmentally, they are not ready. The saliva production they do not have enough enzymes to digest the food. The kidneys are not mature enough to tolerate the large amounts of protein load which any other food could provide. And most importantly, the immune systems are still immature. And this is when they have a maximum risk of developing food allergies. Now, what about before 6 months? That is from the 4 to the 6 months. So why not start after 4 months? Because studies have scientifically proven that complementary feeds introduced before 6 months, that is during the 4 to 6 months, does not improve the growth even if you provide the complementary feeds under the most optimal conditions. Because for the main reason that it tends to displace the breast milk. And we all know that the production of the breast milk is at its height when it comes to the 6 months. But having said this, I would also like to mention that in certain circumstances, like a low birth weight baby or a mother being grossly anemic, some of the micronutrients, especially the iron, may become limiting even before 6 months and may need to be supplemented. Now, after 6 months, what happens? It becomes increasingly difficult for the breastfeed alone to meet the nutrient needs of the child. And most of the infants are now developmentally ready for other foods at about 6 months. And this is an age where if we say that, fine, I'd like to keep the baby safe, do not expose it to other microbials, even if you give the food or not, the baby begins to explore actively. And so they are getting exposed to microbial contaminants. So the chance of allergy is all anyways there. Thus, 6 months is an appropriate age to introduce the complementary. Now, how do you know whether the baby, because as I said, 6 months, most of the babies, how do you know that the baby is ready for complementary? One, their appetite is no longer satisfied from the breast milk they used to get. And then even after feeding very well, 8 to 10 times within a 24-hour period, the baby seems to be hungry, keeps crying. And the baby is able to sit up, at least assisted, and able to lean forward. And they're able to bring the food or the objects to their mouth and try to chew the food. They can hold their head up and have enough control to turn it and say no. That is, they have a control over what to eat. They're able to push away the objects. They no longer want. They learn to say no. This shows that they can push away a spoon to tell you that, yes, it is enough. They start showing an interest in food. The babies may open their mouth, lean forwards, and drool when they are ready to receive the complementary feeds. And we also know that the sound of the food being prepared, the baby starts reacting to all those small things, the sound of the vessels and all that, you can know that the baby shows an interest. Now, developmentally, the readiness of the baby, at around 5 months, the biting movement of the jaw appears. At around 6 months, the baby starts developing the bite. The baby has already achieved the head control. Hand-to-mouth coordination and self-oral stimulation is more or less at this age. Baby starts enjoying the mouthing and the biting. They take whatever to the they get to the mouth and start biting. And the tongue thrust, which was the tendency to push the solids out of the mouth, which is a major enemy of complementary feeding, decreases. And because the baby is now almost getting ready for the eruption of the teeth and there is a hardening of the gums, they like to chew and gum the semi-solids. Also, coming to the biological aspect, the intestinal tract is more developed. Now, immunologically, their baby has a better defense mechanism against foreign proteins. The ability to digest, actually the intestinal amylase and the other enzymes mature, so they can digest proteins, fats, and carbohydrates other than those in the breast milk now. The kidneys are able to excrete the higher load which we provide. And also the neuromuscular mechanisms have developed for recognizing and accepting variations in the taste, consistency, and the color of the food. Now, for what about premature babies? For premature babies also, the concept of complementary feeds is more or less the same as full-term babies. But however, we should take into consideration their corrected age. That is the age when what they would have been if they were born at full term, and we cannot force feed a premature baby. Now, coming to the complementary feeds, when giving complementary feeds, this is one thing, these are the fatwa. This is what we bear in mind: the frequency, the amount, the thickness, the variety, the responsive feeding, and the hygiene. Now, about the meal frequency and the energy density. For an average healthy breastfed infant, the meals of the complementary feed should be provided at least 2 to 3. This is at the beginning at 6 to 8 months, at least 2 to 3 times per day. And as the baby grows older, naturally the times have to be increased. The appropriate number of feeding depends upon a lot of factors like the energy density of the food which you are giving to the feed. And in between, you have to remember the baby is also breastfeeding. So depending on the number of the breastfeeds the baby is getting, how energy dense a meal the baby is getting in between, the timings have to be adjusted. So you can go on increase to 3 to 4 times per day at 9 to 11 months. And by 12 to 24 months, along with that, you can add nutritional snacks. And by snacks, we define the snacks as foods which can be taken in between meals, usually a convenient, easy to prepare and self-fed foods which the baby can take. Now, what about the amount of the complementary feed needed? We start at 6 months of age with small amounts of food and increase the quantity as the baby gets older while maintaining frequent breastfeeding. The most important thing when it comes to counseling a mother regarding complementary feeding is we really have to be realistic. I learned this from my teacher, Ashok Kumar sir, because he was my child's pediatrician. He is the pediatrician, the patient's pediatrician. He never gives importance to the parents. His priority was always the child. So he used to say, let the child reign over you. Let the child decide what the child wants to be. So at 6 months, a child, there's a limit to how much quantity you can increase in the child while maintaining frequent breastfeeding. So the quantity has to be slowly increased. And by an average, along with the energy needs for an infant who takes an average breast milk intake in a developing country at around 6 to 8 months is 200 kilocalories, and 9 to 11 months is 300 kilocalories, and 12 to 23 months is 550 kilocalories. Let's get to the practical aspects. Now, what about the food consistency? So gradually you have to increase the food consistency and the variety of the food as the infant gets older, adapting to the infant's requirements. So initially at 6 months, the baby can eat puree, mashed, and semi-solid foods. Here I'd like to highlight one point. When we say puree, we really have to make it clear to the parents that pureeing doesn't mean using a mixer grinder. This is the biggest mistake most of the parents do. So they mash it up in the mixie and give. So that is not the pureeing. By pureeing, you cook the food well and make it into a puree consistency. And mashing is actually odachedukka. You have to break it down into the smallest piece possible with your hand or a manual equipment. The mixer should be out. It's only for and that's at 6 months. And by 8 months, most of the infants are ready to take finger foods. That is the snacks which can be eaten or handled by the child alone. By 12 months, most of the children, if going in the right path, they can eat the same type of food as consumed by the rest of the family. Only thing is the quality of the food. Keep in mind the need for a nutrient-dense food. We have to design the food for the child. That's all. Now, avoid foods. This is consistent that can cause choking. So the shape and the consistency of the food has to be carefully chosen, because we have to avoid those things like nuts, grapes, and raw carrots and all, which can get easily lodged in the child's trachea. Now, the most important thing, how to feed. So there's only one answer, that is responsive feeding. Means reading or responding to the baby's cues. The baby shows that readiness to feed and that happiness in feeding. The only thing is the mother has to be taught to learn those cues and go according to them. Let the baby guide you to the feed. Now, responsive feeding means it's actually a mother-child interaction while feeding. So specifically, when it comes to responsive, the important points to be mentioned: feed the small infants have to be fed directly, and bigger children just need to be assisted when they feed themselves. And most important, you have to be sensitive to what they are trying to tell you. They cannot speak, but they're trying to tell you when they are hungry and when they have satiety. Both this we have to understand. And the feeding has to be slow and patient, and children have to be encouraged to eat. There is no point in forcing them to. And if a child refuses the feed, stop for some time. You can experiment later, changing the form in a different combination, changing the taste a little, the texture a little, and most importantly, the method of encouragement. And this is again yet another big mistake which parents do: distraction during meals. We always ask the parents and they say, I just show the TV or I show the mobile and then I put the food in the mouth. The child doesn't know and she eats. So this is not how a child should. The feeding should be appreciating the meal which the child is taking. So minimize the distractions during the meals, and also remember that complementary feeding, just like the breastfeeding time, it's a period of love and learning. So talk to the child while feeding, maintain an eye-to-eye contact, and let the child appreciate the feed. Now, again, coming to the developmental aspect, you have to learn that the child is growing. This is yet another problem which I, as a pediatrician, have noticed in parents. They start right. They start the puree at 6 months. They continue with this puree. They continue with the urava, as they say, until 2 weeks. not allow the child to take a dosha or an idli when the child is ready to take it. At 2 months also, the child will be taking the same amount of puri which they started off. So their beginning was right, but they didn't know when to change to the next step. So around 6 to 7 months, the child is able to start swallowing solid foods, bringing the food to the mouth and starting to self-move. And side-to-side movement of the tongue, what you call a rotary chewing, by chewing the food on both sides. That starts by 8 to 12 months. And by around 12 to 18 months, the child is able to drink from a sipper without help, holding it on both sides. And then slowly they can start drinking from an open cup with some spilling, which is actually allowed, because complementary feeding is supposed to be a messy business. Now, what exactly to feed? There is no such thing as what exactly to feed. Whatever is appropriate for the child, what is easily available, and what is affordable to the parents. So you cannot dictate exactly, a dietitian cannot prescribe a complementary diet. It is up to the mother to decide what is best for the child, staying within the dictum of what we advise. Some of the common principles would be: start from simple to complex, from a monocereal to combinations. You can go on to combinations, different combinations of cereals and pulses, which have their advantage of increasing the calorie value. Always best to get the child accustomed to the locally available staple foods like idli, dosha, ragi, chapati, roti, whatever is there, whatever our cultural or what is being used in the household. Let the child get used to it. Mashed banana, other pulpy fruits, sweet potato, all these can be added to the diet. Milk-based cereal preparations, once you're ready to add milk, cow's milk, there is a little bit of controversy on that, when to add cow's milk. Basically, the problem is cow's milk, we always relate that to a cow's milk protein allergy. But nobody tells an exact age at which cow's milk has to be introduced. Is it 1 year, 1.5 years? There is no dictum like that. So if you are ready to introduce cow's milk, it can be added to the cereal preparation. But when the child is feeding the mother's milk, there actually is not much of a need for taking a cow's milk before the age of 1 year. So we can very well keep it beyond 1. Now, sprouts, pulses, legumes, groundnuts, almond, cashew nut, raisins, all these are good, but the importance is that how you give them. Nuts are notorious for causing choking. So when you advise a parent to give nuts, you should also tell them what form to give and to be careful while giving. So this is what we finally target when it comes to complementary feeding. I will not go into the details, which we all know here, the right balanced diet. This is our ultimate target when it comes to complementary feeding. But then again, it should start slow. You cannot, Rome wasn't built in a day, so wasn't complementary feeding. So complementary feeding cannot, you cannot start the first day itself. We have parents coming to us and saying, okay, I've started ragi, so shall I start banana tomorrow? Shall I start apple tomorrow? I give apple morning, I give carrot in the evening. Yes, it is with it. Those are the over-enthusiastic new-gen mothers which we see. So yes, they are right, but also tell them to go slow and slowly let the child get accustomed to the diet. Now, these are the basic dictums. Dietary diversity, a variety of food to meet the nutrient needs and expose them to various tastes and textures, especially flavors. The child is actually exposed to the flavors from a very early stage, even when the mother is breastfeeding the child. This is because even when the baby is in the mother's womb, because we always say the mother's diet goes to the child. So whatever flavors the mother is getting, the baby is getting a hint of it via through the placenta. And also when breastfeeding, the baby gets accustomed to the smells, the mother's feed, whatever the mother takes. So the baby is used to the smells of the diet. That's also very important. So slowly you can introduce a variety of foods to meet the nutrient needs and expose them to various tastes and textures, and minimum diversity, at least 4 or more. As we go on, at least 4 or more of the food groups should be added to the complementary. Try to get it into the complementary diet. And the more diversity you allow, it is not just, one is introducing them to what future they go into. Second thing is, the more diversity you allow, you're more likely to meet their micronutrient requirements, including the need for vitamin A, iron, calcium, thiamine. Now, the nutrient density, we know that the young children have a very limited stomach capacity. So there's no point in just telling the parents to increase the diet just like that, because there is a limit to what the baby takes. So, but what you can do is, whatever you give, you can make it better, improve the quality of the diet. like what I try to tell the mother is, if the child takes only half a dosha, make it a onnondara dosha aaki the nutrient can be improved. Now, cereals and plant-based porridge, this is which we start with, ragi, but that alone is not enough to provide the sufficient energy, the protein and the micronutrients, especially as the child keeps growing. Then the fat, coming to the fat, yes, we give fat, but the quality of the fat which we give, because the good quality fat is found in fish and seafood, nuts, seeds, soya. These are the things which are usually or classically not there in our classical complementary feeding. So the child gets fat, but not what we need, what the child needs for promoting cognitive. This is one aspect where we are lacking a little behind the Westerners, because though we introduce a non-vegetarian diet, we are a little apprehensive about when to start the non-vegetarian diet. Because non-vegetarian diet has its own advantages when it comes to vitamin B12, and the fish has its advantage in omega-3. Now, nutrient-rich and energy-rich food should be fed in age-appropriate and not very excessive portions. And when it comes to nutrient-dense, we need meat, eggs, and the animal sources are good, rich sources, legumes and nuts, and especially groundnuts. Now, the nutrient, how to improve this is a very important thing when it comes to counseling the parents. So how to improve the nutrient value? The nutrient value can be improved by increasing the energy density, by adding ghee, sugar, jaggery, vegetable oil, and butter. But when you say this, I would request to add one more word to the parents. When you're adding ghee, make sure that you add it to the point where the child appreciates. Just for the purpose of adding, you cannot just add 1 spoon of ghee to something. Because start slow. See whether the child is appreciating it. Even jaggery, it is beyond a certain limit. There's no, the child might even vomit. So you have to keep the sugar and the jaggery to a lower limit. But these are the things which you can add to improve the nutrient value. And the protein content by combining cereals and pulses, and certain different cooking methods like milling, germination, fermentation of the food items definitely go a long way in improving the nutrient density. And viscosity of the foods is a big problem because the children cannot eat viscous food. So the viscosity can be reduced by malting. Malting is a process by which you germinate a whole grain, and then the germinated cereal is dried and grinded, and in that way the baby can eat more. So malted cereals, pulse mixed infant foods and all will definitely provide more energy. So does the amylase-rich flour and the other flours which are available. Now, inclusion of animal sources, foods, vegetables, and fruits. These are a good source of high quality protein, and they should be introduced preferably a little more early than what we do now, as the first foods which the child can eat, because they're key sources of nutrients like zinc, iron, vitamin B12. This is what Sir was talking about, that hidden hunger. Hidden hunger can, to a certain level, be avoided if we use a good variety of food when it comes to complementary. Fruits and vegetables, vital components of a diet, but remember that they're just a component of the diet and not a full diet. So you have to maintain a balance when you add all these things. Inclusion of fortified foods, it's not a strict no. That is what I said. In the present era, it is always better to come down to a practical level. You can allow micronutrient powders if you feel that the quality of the food is not good enough. Fortified foods are not all wrong. So they can go a long way as an important source of micronutrients if you feel that the quality of the food is not good. Now, what should be avoided? Drinks or foods of low nutritional value, especially sugar-sweetened beverages, candy, chips, and other foods. This is the actual junk food, what we call. This contribute just some energy. And the biggest problem which they do is they displace the breast milk and decrease the child's appetite for even more nutritious. And the consumption of sugar-sweetened beverages by young children is associated with an increased weight gain, the body mass index. And we see a lot of 1-year-old children, babies with 15 kg, 12 kg weight. So all this junk foods go a long way in adding on to that. Commercial complementary feeds, sorry to say that they are also, the children prefer the commercial complementary feeds compared to what we give from the family foods. This is because they naturally have to increase the taste and the texture. So this will make the child more interested in it. So, but this has a disadvantage. This makes the child less interested in the family foods. Now, trans fats, which is the type of fat seen in processed foods, should be avoided because clear-cut scientific link is there to their association to inflammation in children and the later onset of chronic diseases. Avoidance of added sugars. This is in addition to what is there in the diet. The caregivers, especially the old grandfathers, and they have a habit of adding more sugars to the foods and the beverages, making it more palatable to the baby. But actually, we are altering the palate of the baby. We are creating a taste for the sugar in the child. This can contribute to an excess of energy intake and cause dental caries. The consumption of sugar too, what it produces what is called sugar tooth in the child, and the child starts developing a taste preference for sugar. Fruit juices have the same problem. Nobody gives a fruit juice without adding sugar. That is the biggest problem. They give, and also it's always better to give a fruit as such rather than a juice because of the fiber which comes in. And not only that, as I said, fruit juice, they often add sugar and make it that makes it negative. Now, what about the breastfeeding? This is something where there is no debate on. It has a relatively high fat content, better and good for the child. It is a key source of energy and essential fatty acids. It provides substantial amounts of micronutrients. So breastfeeding, it is always better to continue it till at least 2 years, and beyond that if the mother wants to. And the most important practical importance is when the child falls ill during periods of illness, even if the breast milk is not a very rich source of protein, it is not adequate for the child's calories, the child's appetite may completely go down, but the child continues to take the breast milk. So it is a lifesaver in those opportunities. Now, we cannot overlook the safety aspect when it comes to complementary feeds. We have to advise them regarding the good hygiene, proper food handling, washing of the caregivers as well as the child's hand, because the child is equally involved, storing the foods carefully. The storage equipment as well as the serving utensils have to be kept clean. And feeding bottles, it is very, very difficult to clean a feeding bottle. And most of the parents just wash the feeding bottle. So it is better to avoid. This is yet another reason for avoiding feeding bottle and going to the glass. Now, what about milk products? A controversial issue, as I said before. This is important for the growth, but the baby is taking mother's feed. So I think till 1 year, cow's milk can very well be avoided. And after that, also we see a trend of some relying heavily on goat's milk, which can lead to megaloblastic anemias. And also another thing, the parents, the reason why they consider dairy products as good is because it is a source of calcium. But there are other sources of calcium. Ragi is a good source of calcium. There are other sources of calcium which the child can take. And the most important thing which we face, one problem is avoid only milk feeds or more of milk feeds. When the child uses, we have parents giving children 2 to 3 glasses of milk. So here what happens, this cannot completely replace or substitute the rest of the complementary feed. So child takes off the child's hunger. The child will not have other things. Such children are notorious for micronutrient deficiency. And the parents will not know because they will gain weight. Now, the association of complementary feeding to early childhood and adult diseases, lack of awareness about the nutritional quality. So both aspects, the undernourished. So the the Barker's hypothesis is SGA babies who were overfed, they can lead on to later adult onset diseases, and also overfeeding of the child can lead on to obesity later on. And as I mentioned earlier, complementary feeding goes a long way in deciding how and what an adult eats later in life, though many of the parents are not aware of. Now, the early diverse diet also influences. What about allergy? Yes, again, a controversial topic. Yes, complementary feeding does expose the child to allergy. The early diverse diet. So that is why very early diverse diet we are not seeing. It's after 6 months. The early diverse diet influences the susceptibility to allergic diseases due to the contribution to the diet, because all these components are allergens, and many of the specific dietary components like eggs, milk, fish, peanuts and all we all know they are common allergens. So now comes a question whether to expose the child. These can elicit an immune response. So whether to expose the child to the allergen or not. So the recent evidence indicates that early introduction of allergenic foods may favor a natural tolerance to these allergens. So it's up to us to decide whether to keep the child inside the bubble or let the child out and enjoy the bubble sounds. So how long can you protect the child? So there's no point in protecting for too long. It's better to expose them little by little so that they get used to the allergens. So definitely evidence is for early introduction of allergenic foods, though at a now flavors, as I said earlier, what flavors to give the baby? a bland diet or flavors, you do have to introduce flavors. The flavor bridge from the mother is the mother is the flavor bridge between the to the fetus. So the mother provides initially the flavors because the taste buds start developing very early, even in the fetal state. Even a salt reaction at forges, this has a negative aspect too. So if you start adding too much of salt, the child gets accustomed to that salty diet and they go on. And salt, we all know, is not exactly a good thing to add in extra. So during the complementary feeding is also a taste training period where you're training the child to the taste which the child is going to get. And as a rule, babies have more taste buds per square centimeter. So the more they do not perceive salt and sweet like us. For them, the perception is even more. At this point, I'd like to just bring up, this is probably not important when it comes to complementary feeding, a concept of sensory eater. There are certain children, a sensory eater is someone who experiences sensory overload when eating specific foods. So these children have a sensitivity, a gross sensitivity to certain smells, textures, flavors. So they react very strongly when presented with these foods, the foods which they do not prefer. This is actually seen more in autistic children or autistic spectrum disorder children. So they react very violently to certain things. So here the treatment itself is not to completely avoid, but to slowly introduce the new textures, gradually increasing the flavors in a non-stressful environment. The child has to be introduced to that. Why I'm mentioning this, I want to mention this at this point is at 6 months, at 8 months, we really do not know what the child is going to be. We are not picking up an autistic child at 6 months or 8 months. So very well we could be dealing with an autistic child at this point. So this has to be borne in mind. Another concept I'd like to bring up is, I'm not a absolute propagator of this, but I'd like to bring up the point of a baby-led weaning, something which is more of vogue in the Western area now. In baby-led weaning, the parent provides the food, but the baby or the infant is in control of exactly what and how much they should eat. The infant is also encouraged to join in as early as possible to the family meal times. The infant is never hurried or forced to feed food. This is exactly an extension of responsive feeding. Because when you consider non-responsive feeding, here we are completely overriding the child's internal hunger cues, the satiety cues. So the child finally loses the ability to respond, to tell you that I want something or I don't want something. They lose interest. It is just like they open the mouth and you feed. So in baby-led weaning, it is exactly the opposite. It is sort of like a self-feeding, where the babies are allowed to explore and feed themselves with finger foods from a young age. So this concept started when the complementary feeding age was shifted to the 6 months. Because by 6 months, the baby is now with a unidextrous feed and the baby, but we have to be extremely careful with this method. Babies typically are able to self-feed at around 6 to 9 months. They can sit up unassisted. They can bring the objects to the mouth. So finger feeds can go a long way. So you introduce finger feeds. This is a very messy business because the baby will mess up the area, but that's also a part of the learning process. So here you have to use baby-friendly utensils, soft spoons. This will make the meal time more fun and enjoyable and avoid the stress both for the parent and the child. But you have to be really patient and persistent with the child. So the advantages of baby-led feeding, the propagator says, this allows for better development of fine motor skills. The self-feeding baby has to use their hand and the eye better. So they themselves start using their skills better. This brings up in the baby starts controlling the pace and the quality. So there is a sense of independence and self-regulation in the baby. Regarding the choking risk, some of them say that the choking risk is less because the baby is putting the thing, the baby is aware of what they're putting into the mouth. But this is again said as a disadvantage of baby-led weaning. Too, it is understandable because under supervision, this has to be strictly done under supervision because definitely there is a risk of choking. And this baby-led weaning allows better exploration of flavors and textures and a positive, this is the most important or the most biggest benefit I saw in this, a positive relation of the baby with the food. But the disadvantage, as I said, the risk of choking, I don't know whether it is a benefit or a disadvantage, maybe both. Nutrient deficiencies, unless you have, the parent should also be involved. It is not like allowing the baby absolutely. Parent is stressed because of the possibility of choking, and also the parent will be concerned whether the baby is getting what the baby needs. messiness, food wastage is part of this. Developmental readiness, that is a very important point. 6 months cannot dictate terms. Not all 6-month babies are developmentally ready. That was why the initial slide was whether the baby is ready to meet the challenge of a complementary. Now, parents have to be extremely careful, ensure that the food is appropriately sized and cut, avoid offering whole foods, which could be a choking hazard. Always never leave the baby unattended. Supervise the baby during meal time, and introduction of new food should be one at a time to identify any allergies or intolerance. Now, the search for the best method is up to yet to come. So ours is a traditional method. This is a baby-led weaning. Then I would say the best method would be a combination of both, incorporating the good points of baby-led weaning into our traditional complementary feeding. Now, feeding during illness, just a word of caution, you have to absolutely increase the fluid intake, allow frequent breastfeeding, and encourage the child to eat soft, appetizing, and whatever the child usually likes. Here's where the doctors should come. It is not good during illness to tell the parents to curb down on the diet. It's better to allow the child to take what the child likes. Because after illness, you can slowly start giving more foods to the child, because this is the time when you somehow have to coax the child. The maximum the child might take via breastfeeding or a diet which the child likes. Now, my references, of course, the Bible of Nutrition, Elizabeth Madam, Nutrition and Child Development, and the WHO guidelines and the UNICEF guidelines. And I did refer some of the papers from Advanced Nutrition Chart. Thank you for your patient listening. I know I have not added much to what you know. This has just been a discussion, and there are more than queries. I'm open to negative criticism, because there are more than enough experts in our meeting who can answer this. So open to discussion. Thank you. Thank you all for the patience.
Thank you, Rekha, for that exhaustive presentation. And actually, you have told us many things which we never knew, and which we had some doubts, something we wanted to clarify. So it was very good, actually. And
thank you, madam.
And another thing is regarding this responsive feeding and also baby-led weaning. These things, actually, now what we see is always it is a war between the mother and the child. And the child doesn't want anything, and the mother will be forcing. And every time when the food is taken, the child will be crying, and it always happens like this is something. This is always a question. And another thing is regarding this introduction of allergens. This is very important, because if you are not at all introducing allergens, then your Th1 Th2 hypothesis comes there, actually. And the chance for allergy is more if you are introducing allergens very late. So that is also very useful point. And I was reading, just because I took the complementary feeding, and I was reading regarding this baby-led weaning, and they were telling, like, now it is the period of this vegans and other people, and so when it is baby-led weaning and the parental food is also very much deficient in nutrients, that will also affect. So we cannot completely depend on the parents and the taste of the child. And also, as Rekha said, it is actually a combination will be a more rational one. And we will, if anyone has any comments or queries, you can ask.
Kalpana, I think we'll change the pattern of discussion in this case. Previously also I wanted to tell, let the speakers finish and the discussion be at the end. The previous...
Like both discussions after the end of
at
both
the end, that will be better, because the second
sir,
speaker will not get enough time.
No, well, sir, but the problem was that when we do it the second like that, usually the questions will be to the second speaker alone. That is what I have seen. So usually this talk was a little late. It took a little more time. Otherwise, if we are taking some 10 minutes for one discussion, that problems will be addressed. That is what I felt, sir.
But the second speaker will not, you can't do justice to the second speaker. That's a usual pattern for the last I am observing for the last few sessions. I feel this will be a better thing. Let us hear from the experts first. The discussion, of course, is important. That's what I.
Yes. Okay, sir. So we can move on to the next topic then. Actually, Dr. Reshma, Dr. Reshma is our dear student in SCT Hospital. She's the student of Vijay, my husband, as well as mine, and she has done her DM in endocrinology and has recently joined back to the medical college as the assistant professor in pediatrics. And we can hear from her regarding the hypothyroidism. Actually, she has presented the same talk in IMA Karakutam. So this is a hypothyroidism across the life cycle. So it includes both children as well as adults. And I told her to just continue the same presentation, because now many of the doctors or their relatives are having hypothyroidism. So it will be of use to them also. Over to Dr. Reshma.
Thank you, ma'am. Ma'am, am I audible?
Yes, yes.
And are my slides visible? Ma'am, am I audible?
Yes, yes. You're
Audible.
audible.
Are my slides visible?
Yes, yes. It is very well visible.
Okay,
We can continue.
Okay, thank you so much, ma'am, for this wonderful opportunity. So, as I was hearing Rekha ma'am's talk, as it was a bit extensive, so I decided to cut short on my slides. Some parts of the adult part, actually, I have hit the slides. Okay, so without much delay, let's move on to the cases. So, being clinicians, whichever topic we study or we read about, first of all, we should know about the physiology. In this august audience, I'm sure all know the physiology of thyroid gland, but still, there is hypothalamus, which secretes the thyrotropin releasing hormone. Then we have the anterior pituitary, wherein it acts to produce the thyroid stimulating hormone, which is going to act on the thyroid gland. And we have T4 and some T3 that is produced from the gland. And the T4 that is produced from the gland is getting converted to T3, because T3 is the active form, and that is what is going to act on the tissues. So the body keeps in check this process by inhibitory mechanisms like T3 and T4 exerts an inhibitory feedback at the level of anterior pituitary and the hypothalamus. So the first case is very simple for us pediatricians. Easier said than done. So a 5-day-old baby came with complaints of constipation, and on examination, baby had caustaceous and umbilical hernia, which is usually not the case. And then there was the TFT report. So here we can see that this baby is now 10 days old, and the report shows that free T4 is in the normal range for a newborn, 2.25 nanogram per DL, and TSH is more than 100. So whenever we get a report, we should always take into the clinical aspects also. So this baby was started on thyroxine, and hence the T4 level is now normal and TSH is still elevated. So here there is no doubt in the diagnosis that it is a congenital hypothyroidism. So what are the clinical pointers towards congenital hypothyroidism? So wide open AF and PF, that is anterior fontanelle and posterior fontanelle, prolonged jaundice, that is more than 2 weeks in a term baby and more than 3 weeks in a preterm baby, a baby who is sleeping more and crying less, macroglossia, constipation, umbilical hernia, dry skin, all are clinical pointers towards congenital hypothyroidism. So usually we have newborn screening very robust in our state Kerala. So usually the dose is 10 to 15 microgram per kg of thyroxine. So the doubt arises, like a patient, a baby is 3 kilogram and is having congenital hypothyroidism. So the dose will come to nearly 45 microgram. So better will be to start on 50 microgram, because the tablet strength available are 12.5, 25, 37.5, 50, then 62. So nearly the better one is 50. So because it is a small tablet, then crushing it and then dividing it and then mixing it in milk or water and giving the baby will be tedious. So nearly the dose which will come nearby to the calculated dose we should preferably give. Now, this is the ISPE guidelines. ISPE is the Indian Society of Pediatric and Adolescent Endocrinology. So, the heel prick sample or cord blood TSH in the first screening. So, if it is more than 20, maybe more than 80, more than 40, or 20 to 40. So, if it is more than 80, take a confirmatory sample, but start levothyroxine treatment immediately without waiting for reports. And now if it is more than 40, we have to take another sample once the child is more than 72 hours of age, that is TSH and free T4 or total T4. Then if the child's TSH is 20 to 40 or 34 to 40 in a sample taken at 24 to 48 hours. This is because we say that TSH less than 20 is normal in the first screening. So if the screening was done before 48 hours, it is less than 34, that is normal. So if it is 20 to 40, we will again do a screening at 7 to 10 days, wherein we repeat the TSH. And if it is more than 20 and the age of the child is less than 2 weeks, or it is more than 10 and age of the child is more than 2 weeks, we do a confirmatory sample, or straight away we can do a confirmatory sample when the child comes after 72 hours of age. Now, when we do the confirmatory sample of taking TSH and T4, there are three scenarios that can happen. There can be a normal T4 and high TSH. So we have told that it is more than 20 for less than 2 weeks and more than 10 for more than 2 weeks. With normal T4 and free T4, then we can again wait for another 2 weeks. And if the TSH goes to less than 10, it is normal. But if it is still more than 10 after 3 weeks, even if the T4 is normal, we have to start treatment. Then again, low T4 values irrespective of TSH. So the values given are low free T4 less than 1.1 nanogram per dl and low T4 less than 8 microgram per dl irrespective of TSH, or free T4 less than 1.17 or T4 less than 10 and TSH more than 20 or more than 10 if the child is more than 2 weeks. So these values, I know it's very difficult to get into our head. So what I have done is taken a screenshot and saved in my phone so that whenever a child comes, I can quickly review like which category the child comes in. Most of the values I do remember, but the very minute details, it's difficult to remember. And if the T4 and TSH are normal, then it is normal. Nothing more to be done about it. Then always, as all newborns, for all newborns, preterm and low birth weight babies should also undergo routine screening at 48 to 72 hours. And sick neonates should be screened at least by 7 days of age. But all these newborns, it will be better to have a second screen at 4 weeks of age or at 2 weeks of age if they are discharged early, because there are certain things like sick thyroid, or if it twins with the same sex, there can be a difference in the value of one twin. So we should always, it will be better to repeat a screening for them at 4 weeks. So one more doubt we all have is, when can we do the scan? Like, should we wait to start the treatment? It is always better to start the treatment because we don't know when we can do the scintigraphy. Ultrasound neck can be done at any time, and scintigraphy can be done up to 7 days after initiation of medicine. So when we start the medicine, the TSH comes down. So all the scintigraphy, even if it is the technetium 99 or the iodine 131, it all uses the sodium iodide symporter, wherein a major stimulus is the TSH. So the TSH will start to come down by 7 days. That is why we are not doing it after 7 days. But if in doubt, it is always better to start the treatment and then plan on the ultrasound or the scintigraphy later on. And if it is a case of congenital hypothyroidism, till 3 years, we will give them the medicine. And at 3 years, we can stop the medicine for around 1 month and then again see. So this was a case of congenital hypothyroidism. Now going on to a young boy, like a 7-year-old child presented with fall, with hit on head and vomiting. So the treating pediatric surgeon took an MRI, which showed pituitary gland enlargement. Luckily, he had a TFT report too. So these are the findings. That is, the pituitary gland was diffusely enlarged. So these are two images. The image that I am projecting now is of the actual child, and this is a representative image. So you can see that here, this is the pituitary, normal pituitary. So here our pituitary is definitely enlarged with the upper surface a bit convex. So what is really happening here? Luckily, the TFT report was there. TSH is 403 and free T4 is 8.55, which is corresponding to 0.66 nanogram per dl. So this child is a primary hypothyroid child. So what exactly happened here? The learning point is, so TSH is increased due to the primary hypothyroidism, and that is because there is thyroid probe hyperplasia that is resulting in the pituitary gland enlargement. So here the treatment is only supplementing thyroxine and there is no need to do any surgery. So one thing is dose is different. 7 kg child, we will not start at 10 to 15 microgram per kg, or the adult dose of 1.6 microgram per kg. He needs a bit more higher dose. So usually, roughly what we say is 1 to 3 years, it is 4 to 6 microgram per kg. 3 to 10 years, it is 3 to 5 microgram per kg. And 10 to 16 years, it is 2 to 4 microgram per kg. And adult dose is usually 1.6 microgram per kg. And again, we usually don't start the full dose at the initial stage itself when the child comes, because when the child is hypothyroid, there is something called lazy adrenal. So thyroxine is the hormone that usually metabolizes cortisol. So when the thyroxine is deficient in our body, what the body's adrenal does is it also becomes lazy because there is nothing to increase its metabolism. So when we give thyroxine at a higher dose at the first go, what happens is more of cortisol is metabolized, but the adrenal is yet to pick up from the lazy state. So it is better to start at a lower dose and then hike it up to the actual dose. So now the third scenario, it is a young girl. So she's a young girl, 10-year-old, came with acute onset abdominal pain. And on examination, she had breast stage 3 and periods had started 3 months back. So definitely it is premature for a girl of 10-year-old to have her periods. And USG pelvis showed an ovarian cyst. And the facies were dull looking and she was short. She was only 120 centimeters at the age of 10 years. So a TFT was ordered. So here again, the total T3 was 5 and total T4 was 0.12. TSH was more than 5.2 because the lab assays limit was 502. So here again, some girls can even be present with ovarian torsion and they require surgery. But here, this syndrome is called Van Wyck-Grumbach syndrome, where circulating levels of this high TSH act directly on the FSH receptors on the ovary and maybe actually the mediators of precocity. So this is a pseudo precocity wherein from the ovary there is estrogen that is produced in excess, and this leads on to some breast development and endometrial hyperplasia, which leads on to the menses and also breast development. But the child will be short because the thyroxine hormone, which is needed for the normal height, is not there. Then again, a short. So this was a extreme thing, Van Wyck-Grumbach, but we do see that in between. So normally children come to us, bright girls, bright girls or boys, they don't have much of the stigmata of hypothyroid. But when a child with short stature comes, we have also studied that the first line investigation should involve a TFT. So here again, a short 10-year-old, her father was a medical representative. TSH is more than 100, free T4 is less than 0.04. And the bone age, so the left image is from the Gilson's Ratip Atlas of a 5.5-year-old child, and this was her X-ray. So we can see that there is almost 4.5 years of delay in this child, just short stature. So another query, be it a pediatric population child or a adult person, that my anti-TPO was 100, now it is 80. So is there any 8 to 27% has anti-TPO positivity? And if subclinical hypothyroidism is there, that means T4 is normal and TSH is more than the upper limit of the normal for the assay and the patient is asymptomatic. If that person is anti-TPO positive, there is a twofold increased risk of progressing to overt hypothyroidism compared to an anti-TPO negative person. And if you are hypothyroid and you are anti-TPO positive, it just means that the cause is autoimmune. So there is no much role in monitoring anti-TPO or saying that my anti-TPO is 1200, it is so much elevated. So anti-TPO positivity means it is autoimmune or it can be even normal. Then another query is obese people, like it can be a child or an adult who comes to us saying that the obesity is totally due to the thyroid problem. So T3 here is normal, T4 is normal, TSH is 7. So this is again a subclinical hypothyroidism. So again, there is something called, so that there is no need to treat such a person. So in obese person, the adipocytes will be more. So leptin hormone that is secreted from the adipocytes will be more. So leptin hormone is increased, and this has a stimulatory effect on the TSH secretion. So if they lose their weight, their TSH requirement will come down automatically. But what happens is most of these people end up receiving a placebo dose of 25 microgram, which will not do much help to them, but still they will be happy. So ideally, we should not give them medicine and counsel for weight loss. Then this is not per se hypothyroidism, but as we are discussing thyroid and we do get to see a lot of TFTs. So a girl with hair loss is going to a dermatologist, and the dermatologist has ordered TFT. So T3 is 190, it is elevated. T4 is 16.6, it is elevated. TSH is 0.01. So always we should always write the values with units and compare it to the laboratory normal. So this girl was on biotin gummies. So normally our daily requirement is 50 microgram per day. So here 50 microgram per day. So here this girl is taking 10,000 microgram or 10 milligram. So what happens is, so there are many clinical reports wherein biotin interference in routine clinical immunoassays. So one more thing, when such a report comes, we should always examine clinically. So here we have examined, there is no tachycardia, no tremor, no goiter, nothing to suggest hyperthyroidism. So there is something called, so in lab, what we do is immunoassay. So there is an antigen antibody reaction. So there can be competitive assays and non-competitive assays. So non-competitive assays are usually for large molecules like TSH, and competitive assays are for small molecules like T4. So the first assay that is being shown is the non-competitive assay for the, this is the non-competitive assay for the TSH molecule. So you can see that here the analyte is there and it is biotin free. So now in the next step, there is this blue color are the streptavidin coated microparticles. So whenever we are doing an assay, the plate will have this streptavidin coated microparticles, and there is a biotin-related antibody that will come and attach to it. Then our analyte will go and attach to it. Then comes the labeled antibody, which will give the signal. So this looks like a sandwich. This is a non-competitive assay. Normally, so if the patient is having excess of biotin in her body, what happens is this biotin will come and bind on the streptavidin. So we will see that less of signal producing antibodies are there. So in non-competitive assay, it is usually, as the signal is less, we will tend to think that the analyte is very less in the body. So TSH will falsely come low, and this is a competitive assay for the smaller molecule like T3, T4, and it will be read as high. So falsely low TSH and high T3, T4. So this we should always keep in mind, that biotin in excess will have such an interference. There are a lot of interferences in TFT. So always when our clinical examination findings and the report doesn't correlate, we have to think about the laboratory interferences also. Then TFT before surgery, this is something we routinely see in the adults population, like there will be a TFT report and clearance for surgery. So this is a good article by S.K. Badada sir, who is a endocrinology HOD at PGIMER. So what are the issues actually if the patient is hypothyroid? So if the patient is hypothyroid, cardiac output is decreased by 30 to 50%. The adrenergic tone is depressed and cholesterol levels are increased. Multiple coagulation factors, half-life is prolonged. They are anemic and they can have ventilatory dysfunction. So this is a flowchart given in that article. So it is basically if the patient has severe hypothyroidism, that is overtly they are hypothyroid with TSH more than 10. And if it is an urgent surgery, it will be better to give them IV thyroxine, which is not available. We can load the oral thyroxine. Or if it is an elective surgery, it's always better to do the surgery after correcting the hypothyroidism. So if it is mild hypothyroidism or subclinical hypothyroidism, we are not much bothered. But otherwise, if it is a severe hypothyroidism case, it's always better to give clearance once the patient is euthyroid. Now, again, a child presents with thyroid swelling. So it is a classical teaching that adults presenting with thyroid swelling and pediatric population presenting with thyroid swelling, there is a small difference. So the steps of examination and investigation are the same. That is, first we will do a clinical examination and find out if they have the hypothyroid symptoms or hypothyroid, then see for the consistency of swelling, look for the lymph nodes, lower border is palpable or not, we will see, and then we will order a TFT. And if the TFT is coming in hypothyroid range or euthyroid, we will proceed with an ultrasound neck. And there is something called TIRADS, that is the thyroid imaging reporting and data system, which is got from the ultrasound neck, which I will deal with in the next slide. And if the patient is hyperthyroid, thyroid uptake scan is the best option because we can see if it is a uniform uptake or if it is a localized uptake. So coming to TIRADS, so TIRADS has this 5 points, that is composition, echogenicity, shape, margin, echogenic foci. So the ultrasound person, the radiologist, they will give us a score. So total points they will add from this, and TIRAD score finally comes. So here it is 0.0. The point is 0 and TIRAD score is TR1. So the recommendation is benign, no FNAC. So this is the actual thing. So TIRADs 1, 2, 3, 4, and 5 are there. So 5 is highly suspicious. It is highly suspicious for malignancy. 4 is moderately suspicious. 3 is mildly suspicious. 2 and 1 are not suspicious. So there are some cutoffs in which we have to do FNAC and follow up. So again, how are the pediatric thyroid nodules different? So mostly they are benign. We need not worry, but risk of malignancy is higher than an adult patient. Like 25% of the pediatric nodules are likely to be malignant than compared to 10% of the adult nodules. And among similar histology and tumor size, pediatric papillary thyroid carcinomas have higher regional lymph node involvement risk, extrathyroidal extension, pulmonary metastasis. But we can be happy that the prognosis is better with treatment in a child also. Then coming to a very confusing topic like the cartoon I have put, subclinical hypothyroidism, whether to treat or not to treat. So in a subclinical hypothyroid, mostly they revert to euthyroid stage in up to 60% of cases over 5 years, depending on TSH concentration and antithyroid antibody status. And some progress to overt hypothyroidism, that is to the tune of 1 to 5% of cases per year, depending on TSH concentration and anti-thyroid antibody status. We learned that anti-TPO, when it is positive, there is more than 2 times the chance of progressing to overt hypothyroidism from subclinical hypothyroidism. So in a child, it is clearly given in the ATA guidelines that even if the child is subclinically hypothyroid, if there is any concern over linear growth or there is a goiter, because goiter, the stimulus is the thyroid stimulating hormone. So with treatment, we can bring it down. Then is there any evidence of autoimmune disease like TPO positivity, celiac disease, type 1 diabetes? It is always better to start. And also if there is any prior history of radiation for treatment of any benign condition or non-thyroidal malignancy, because if we keep this TSH under check, there is decreased chance for development of thyroid nodules, which is a possibility in the aftermath of radiation. Then, so for hypothyroidism, we use the levothyroxine tablet. We use it so commonly that we should know everything about it. So it is ideally given in an empty stomach, not possible in a congenital hypothyroidism child. There should be a 1 hour gap with food, tea, coffee, or soy containing products because it will hinder with the absorption. And there should be a 4 hour gap with proton pump inhibitors, calcium, and iron. Then this was an interesting discussion that came in the Ped-Endo India group recently. So this doctor is seeing a 10-year-old patient complains of adverse reaction to Thyronome since last 2 months. She's able to tolerate only 12.5, and every time she tries to change to 25, there is swelling of hands and feet. So the mother is a nurse. So what is exactly happening here? So there is a phenomenon called allergy to thyroxine. So it is not that the patient is faking. So here we can see that I have put a color here. So this preparation of 25 microgram has a colorant, sunset yellow, whereas this preparation of 12.5, there are no excipients. So this colorants can sometimes cause allergy. So this is something that it will be good if we know about it. So learning is a constant process of discovery, a process without any end. So thank you so much.
And thank you, Reshma. That is very nice. And it ended so fast, actually.
I had hid some of my slides, ma'am. The pregnancy slides actually I did not keep.
Okay, but it was very nice and very informative. And for questions, sir is there.
Yes. Both the talks were excellent. Rekha, your first talk, Rekha has covered extensively, and a few points which we need to stress to the parents about the recent guidelines. You already, Rekha already stressed on this thing. Adding sugar, because more and more of consensus regarding no sugar, no salt below 1 year. And we should all be talking to the administrators regarding the changing of the Amardam powder using at 6 months onwards. Actually, it contains very high sugar. It is recommended from 6 months onwards. We should change that. At least you should initiate the Amardam powder after 1 year at least. So that is one important point. And today onwards, the health minister had declared the food items in Anganwadi biryani. That is declared. Actually, they're all trying for some political mileage and all. Whether they have discussed all these things with the experts in the nutrition forum, I don't know. Anyway, it's not chicken, it's egg-based. So nutritionally better, more calorie, no more oil, egg-based, that will be better. Anyway, so regarding the other things, adding honey to the younger kids, and the Amardam body from 6 months onwards. There are a lot of things need to be totally avoided or corrected and should be convincing the politicians or the policy makers. And regarding the adding of the egg, conventionally we are adding egg yellow at 10 months and white from 1 year onwards. That was classically we are advising. But in the recent guidelines, more and more we can start a little bit early from 6 months onwards. Egg yellow can be added, and regard stock also maybe we can start the fish and meat a little earlier. That is one thing. And the other one, we are not talking too much about the amylase rich food and the sprouting things are better. That's also to be told to all the mothers. And regarding the newer concept of the allergen introduction earlier, especially in the context of asthma situation, that may come up in the coming years. So because up to 6 months, we are giving only the exclusive breastfeeding, whether encouraging the mothers during the lactation of this type of food, will it be helping rather than directly adding one of these allergen food earlier than 3 months? That may not be practicable. So giving it to the food, whether that will work. So that is all very useful thing. What I suggest is regarding the feeding of the disabled kids. So it's not included in the nutrition people. Nutrition subspecialty will be interested only in the nutrition of the normal child. The cerebral palsy and the other problems, problematic child, some swallowing problem, they'll be looked after by the neurologists, pediatric neurologists and all. Actually, we should be crossing the territory to the other people, and there should be some help regarding the right food, right time, right content in a manner where the difficulty in the feeding, the normal development of the swallowing, coordination, and how you can improve the feeding, that also should be part of the nutrition people. So we are all talking too much only on the normal kids. Why not the kids with some of these problems? Rekha was touching on the autistic kids, the difficulties encountered. Just more important is the spastic kids or flaccid weakness or anatomical problem with swallowing. So there will be some special category where the introduction of the semi-solids and persisting and continuation will be defective, and they again may be slipping on to the malnutrition. So we should be including those kids also in the nutrition part, complement. Both the talks are excellent. Reshma also did very well. Lot of practical points, especially that algorithm. Definitely, what you suggested is right. Whatever number you see this thing, you will not remember. So better to keep that chart in your OP. That will be the only solution. Good talk. Okay, Kalpana.
Rekha, any comments? Parvati madam?
You are mute, madam. Rekha madam is mute. Madam, you are mute.
As sir said, I also have some doubts regarding this. Like that is why I put in the sensory eaters slide, because sensory eating at 6 and 8 months, as sir said, we may not be picking up those children with cerebral palsy, feeding difficulty. So that is one concept probably we have to bring more to attention. So probably those children who are having difficulty in complementary feeding are those children really probably future autistic children or future cerebral palsy. That's what came to my mind when I read about sensory eating. Rest of the thing, thank you, sir, for the inputs.
Parvati madam? Parvati madam, are you there?
Madam is
I'm
mute.
here. I'm here. I fully agree with both talks were really wonderful, I should say. Regarding the nutrition part, I fully agree with Purushothaman that our Amradam Podi, I think it is too sweet. We say that no sugar, no salt before, or less salt and less sugar before 1 year. I think I also have tasted Amradam Podi. It's very sweet. And regarding the problem with spastic children, that has to be addressed. And this tolerance to allergens, that has to be, most of the pediatricians are still, I think, unaware of that. So you should enlighten them with the tolerance of proteins. If you have to start before 1 year, that is the latest recommendation. And regarding the endocrinology part, so many new things I have learned. And I also had a patient who had this antibody, most probably antibody production. She wanted very high dose to keep the TSH normal level. So thank you very much. Thank you for the opportunity.
Srinivasan sir has left. Sir is there? Yeah. Rekha, one more point. You already highlighted, but that should be coming out in the media. Nowadays, the younger kids are much fond of these packets of Lays and other things hanging, and sweetened beverages. And once they are taking these things at home, naturally the mothers will give it to the younger kids. And finger food, they'll also be put in front of the kids. Actually, we should be discouraging that sort of this ultra processed food, sweetened this thing, beverages below 1 year. That should be stressed. By chance, just because the elder kids are getting it and they are all bringing that at home, these kids also will be getting. And they are sweet or salt, and they'll be feeding that, and that taste forever will be changing to the attitude for that. Craving will be developing because you are giving those things. Simple things that should be stressed to the mothers in the future. Small videos. I am making small videos, and lot of our youngsters are making videos, and all these small points would reach the entire society, the negative things, especially the Amridam powder. Somehow the policymakers can only make that change. Dr. Elizabeth or whoever has having some say on the policymakers should insist on these things.
One point I would like to highlight, very nice topic selection and very good speakers. And special kids, you were talking about children with autism, children with cerebral palsy, and most often nowadays as the CKD is also emerging, a lot of low birth weight babies and babies with fetal ESRD syndrome are also surviving infancy, and their feeding becomes a real trouble. Amardam podi and all cannot be used because it will be high in potassium. And another thing is when these babies develop diarrhea and vomiting, giving ORS also will be difficult as hyperkalemia is an issue. So such babies, so babies with special needs, not only autistic children or children with cerebral palsy, but also children with chronic liver disease, chronic kidney disease, heart disease, where salt restriction is imposed. And such babies also should be given an importance. In the Western country, actually, there are formulas which are specifically made for babies with such organ dysfunctions, not only kidney, but other organ dysfunctions also. And at another point that I want to highlight and I want to say at this in this forum is most often we see all these small babies being fed by showing them videos on this phone. And so the screen time actually is getting encouraged. If the baby wants to eat, the baby has to be shown the some videos on the phone and all. So such habits also should be discouraged. Thank you.
Susan,
Thank you,
we are
Susan.
not showing your video behind the curtain.
Only the sound.
And,
Because the range is.
I think Lace has got some sort of addiction. അത്
yes.
തിന്നാ പിന്നെ പിന്നെയും തിന്നോണ്ടിരിക്കുന്നു തോന്നുന്നു അല്ലേ?
Dr. Prashant? Dr. Prashant is here.
Yes, madam. Purushothaman sir has actually brought out a very important point regarding this Amardam mix. I think there are even government documents, ICMR documents, which has suggested that there has to be an overhaul and review of this particular product. I don't think that none of the stakeholders like IAP, etc., are consulted in the formulation of these. These supplements. So it is high time that.
And also it contains all the many things are there.
Yes,
So
lot
one
of
food at a time is also not, all different
and
things are mixed together actually.
And not only that, for a single child, 3 to 5 packets are being issued per month. So that will take a very, I think we are unnecessarily wasting our resources and creating a lot of harm to our small children.
Yes, correct. And also regarding this sweet thing, all mothers are saying we are not giving any sugar, but they are giving this panangarkada or something like other things they are using in plenty. So all are sugars, but people are thinking that they are not sugars.
Even for older children, when we really take the dietetic history, we find that the calorie consumption is many fold higher than what is prescribed as per the RDA. Only after convincing them that they are taking so much excess, we are able to tell them that cut down on high fat, high sugar, and high salt. Even the per capita income, the family consumption, etc., are quite high in Kerala.
Yes.
Madam Susan madam പറഞ്ഞു ഒരു പോയിന്റ് ആ ഒരു സ്ക്രീൻ ടൈമിന്റെ പോയിന്റ് അത് not just a screen time, a very valid point, but screen time is definitely increasing. But in addition to that, when they are fed using the mobile, they are actually just opening the mouth and we're putting in the food. They are not appreciating the taste. They are not appreciating the exactly നമ്മുടെ complementary feeding in the concept is completely different. കാരണം ആ ഒരു ഫുഡിലോട്ട്
And also the quantity, it is often overfed
unpalatable object കൊടുത്താലും അവർ ചിലപ്പോൾ കഴിക്കും. So
and nobody knows what they're taking.
They are not developing the palate. That is also one big point which the parents don't understand. And another extreme of what Sir said, sweet and sugar. We have a lot of, at least in my opinion, I see a lot of new gen mothers. They are all strictly into Google. So other they have no idea exactly. So some of them do not even put a pinch of salt.
That is
So
true.
because finally they have to start sharing the family pot. So I'd like an opinion on that. Like not even adding a pinch of salt. I have a niece who refuses to put even a pinch of salt in the child's diet. So അത്രയും ഒരു strictism, is it good in the long run എന്നൊന്നും അറിയത്തില്ല. Added salt can be avoided, but
all food fats are not good, isn't it? Whatever is natural is relatively better, and all they are thinking, they are reading, and they are practicing the same to the children. That is a little difficult. And also the vegan habits also, not giving anything that is non-veg or even milk or nothing, and vitamin B12 deficiencies definitely we are seeing.
And another point regarding feeding is like there is a rampant practice of giving everything grinded in a mixer grinder and pour it directly into the mouth of the children. So much so that they are not developing the faculty of chewing, etc., etc.
Yes.
So much so even at 2 years, 3 years, they do not know practically how to chew and eat food properly. They just gulp the food as such.
And even a grain in the throat, it will induce vomiting.
Yes, madam. Yes, madam. Yes, madam. They are not able to appreciate the texture, etc., etc. Simply gulping and swallowing.
So no mixie, no bottle, no tin
Yes.
foods. That should be the idea.
Yes.
Reshma, we have to do T4 and TSH or free T4 and TSH for follow-up patients.
Sir, so basically, the ideal assay to do free T4 or free hormones is equilibrium dialysis or ultrafiltration method. So the free T4 done by immunoassay is actually not very reliable. So what I have seen is if it is a good lab, free T4 by immunoassay is okay. But T4 results are always better. So if there is a discordance between T4 and free T4, then we will know the child is having a TBG deficiency or something. So T4 from a lab is equally good. Free T4, if it is a good lab, it is good because the ideal assay is equilibrium dialysis or ultrafiltration, which we are not doing because it is extremely expensive and very difficult. So it's always better to do T4 and TSH, sir, and free T4 if it's a good lab.
And in a patient with congenital hypothyroidism, and which one you have to follow? The TSH you cannot relay. So what is the guide?
Sir, I did not get that point.
See, when you are having congenital hypothyroidism, you will have a high level of TSH.
Yes, sir.
And then you are giving drugs, and most of the time the TSH level will remain high. So how we follow up the patient?
So the TSH will take some time to come down, 4 to 6 weeks, we usually say. So if the child's T4 or free T4 is in the normal range and the baby is doing well, we need not bother much about the TSH. We should give the time for TSH to come down. Sir?
Okay. Thank you.
Okay.
And one more question on ectopic thyroid or something was given. What is that?
Sir was telling that even if we do an ultrasound of the neck and we see that the gland is not there, maybe it's an ectopic thyroid. It is in the lingual region or somewhere down. So it's always better to do technetium scan, but every place technetium scan is not available. So a baseline ultrasound neck to see if the thyroid gland is not there. Again, it depends on the expertise of the radiologist because thyroid gland in a small baby with a very short neck, it will be difficult to see. But still, technetium scan is the ideal because then we can know whether the gland is there or, as I mentioned, if it is ectopic or not.
But we find that most of the time some soft tissues in the neck will be reported as thyroid tissue. And when you do the radionuclide study, there may not be any thyroid tissue. And the usual ectopic thyroid we used to miss is the this lingual thyroid.
Lingual.
So it may not be getting enlarged and you will be missing. And the patient will have a hypothyroidism also. So better we'll go for radionuclides scan.
Again, in congenital hypothyroidism, we should always look at the mouth of the baby also. Sometimes at the back of the tongue, there will be a thyroid tissue. I have seen only pictures. I have not seen in a clinical patient, but we have to like include that in the clinical examination.
I have seen a case is presented with a swelling in the root of the tongue. And when we look for that, the thyroid level was very low. And we started, that is how we picked up. First time they are presenting with a swelling in the root of the tongue.
Root of the neck. So there also we should ideally examine when a baby is coming to us with congenital hypothyroidism or hypothyroidism.
And this thyroglossal cyst is also making some confusion in diagnosis.
Yes, thyroglossal cyst, usually what we see is when we put out the tongue, it will move, but the thyroid swelling will not.
So for a small child, it may not be that easy
It
to...
will be tough. Yes, but thyroglossal cysts, sir, will not usually present with hypothyroidism, I think. Yes.
Vijayamar sir's question, the point is regarding the utility of TSH. Only thing Dr. Reshma pointed out, don't jump into taking a decision based on the TSH if you are doing within the 2 weeks. Because after starting a particular dose, if you are doing after 2 weeks, TSH may remain high, T4 will normalize. And based on that, don't change the dose. At least 4 weeks should be taken. Then only you make a change. TSH will take at least 4 weeks to come down. After 2 weeks, don't change.
So when we change the dose of the thyroxine, and how frequently we have to monitor the thyroid function?
So, sir, when with any dose change, it is ideal to repeat the thyroid function test, that is the T4 and TSH, after 4 to 6 weeks. That will be better.
After 4 weeks?
Yes, after 4 weeks is enough, sir.
Okay.
Because then only we will get a detectable change in the TSH, as we were discussing.
Hello.
Okay. So we had two very good presentations, and over to Srijit for the vote of thanks.
Okay, madam. So we have come to end of today's Tuesday series, and thank both the speakers, Dr. Rekha madam and Dr. Reshma, and also say Purushottam sir, Parvati madam, Susan madam, and all other Vijayamar sir for actively participating in these discussions. So hope you to join in the next time of Tuesday series. Thank you and good night, and join for IPL cricket for those who want.
Thank you.